So we're excited to be with you, that you're with us tonight. I'd like to give you just a little bit of information before we get started. I mean, the first thing is this is an open Q&A. So tonight, if you have any questions whatsoever, we're here and happy to answer them. You can use the Q&A button on the Zoom platform to ask your question. If by chance we're not able to get to your question, it records your question, so of course, we'll get back with you. But I'd like to tell you a little bit about our guest speaker this evening. You guys are, I'm excited to have her with us. Leslie Stevens is with us. She's actually been involved in the world of pediatric sleep, breathing, and airway health for over 35 years. As CEO and president of HealthyStart, Leslie is an international lecturer and trainer. I mean, I don't think there's a question in the reference to the subject of pediatric sleep, breathing, airway, and HealthyStart's connection that she cannot answer. And really, when you have the backing of a company like HealthyStart by Orthotain, you have over 51 years, over 4 million cases, and tons of research to back you. Now, most importantly, Leslie is the mother of 3, so her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. One of the things that you're going to learn tonight is that there is a silent epidemic affecting 9 out of 10 children. This epidemic manifests itself in a variety of symptoms that can be easily overlooked, misdiagnosed, and most unfortunately left untreated. So it's absolutely critical that children are evaluated for sleep and breathing habits. Leslie's mission is to educate both dental professionals and parents to ensure children a lifetime of health, happiness, and success. So I'd actually like to take this time to hand the mic and the floor over to Leslie Stevens.
Thank you so much, Susie, and welcome everyone. Happy early Memorial Day weekend. I am thrilled that you're here to share part of your evening with me, and I promise you it will be well worth it. So let's get started here. So tonight, as Susie had mentioned, we're going to talk a little bit about sleep disorder breathing. Sometimes you hear the ADA refer to it as sleep-related breathing disorder. It basically is the same. A lot of people feel that breathing basically is the onset of a lot of these issues. Some feel that airway is the cause of it. However you want to look at it, I think everything plays a part, has a role, and obviously affects the way a child will sleep. So we'll talk a little bit about how we identify, how we evaluate, and basically when we look at these children, we're going to look at the underlying root causes, and then we are going to treat those underlying root causes, not only for today, but for a lifetime or for a more permanent result for that child. So as I had said, ADA, AAO have all put different determinations, verbiage, language on what they expect their practicing dentist or practicing orthodontist to be doing in the realm of screening for sleep, breathing, and airway issues in children. The ADA has gone so far as to look for basically improper growth and development for a child, and allowing or mandating that the dentists educate themselves in this area. So tonight is the first step in your journey of learning a little bit more about sleep disorder breathing or sleep-related breathing. So when we talk about this, there are outward symptoms that we see in children that basically help us identify these characteristics or these potential problems, and we call them outward symptoms. We do know, our research has indicated that 9 out of 10 children will have one or more of these outward symptoms. So it is quite prevalent. Sometimes we call it the silent crisis among children. 9 out of 10 children represent about 40 million children in the United States. So it is a huge amount of children that have these symptoms, and therefore in your practice alone, you'll be seeing a lot of these children. I would implore you this weekend for all your Memorial Day festivities, just take a look around you. You're going to be looking at children a little bit differently than you did prior to tonight. So what are these outward symptoms? They include mouth breathing, snoring, teeth grinding, swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, pair problems, few friends, bedwetting, difficulty in school, especially in the subjects of math, science, and spelling. We see a delayed or stunted growth, many times restless sleep, nightmares, night terrors sometimes, morning headaches, daytime drowsiness, frequently waking up at night, sleep talking, and walking. So, as a parent, this is a whole gamut of symptoms. And typically, if a parent sees one or more of these symptoms, they are probably looking at them in isolation. They don't understand that bedwetting might have something to do with the child's asthma or allergies, or maybe ADD and ADHD. So, typically, a parent will identify them, isolate them, and basically go to a specialist for um, evaluation and possibly treatment of those symptoms. Unfortunately, a lot of these symptoms are treated with things like drugs, psychiatric testing, counseling, therapy, surgery, sleep study, allergy testing. And so often they only address the symptoms, but they do not address the root cause. Many of these tend to be short term band aids. Many involve several drugs, many with side effects. And unfortunately, it can be costly, painful, time consuming, and ineffective. So when we look at these, we want to actually look at the root causes. What is underneath? What is causing these whole array of outward symptoms? Well, over the past 20 years, probably even longer, research has linked these underlying root causes, and they include mouth breathing, narrow palate, improper tongue placement, and jaw relationships. So, how can you, as a dental professional, screen for sleep? Well, the very first and the simplest is to initiate just by visual. You have an array of clues to pick from when you look at these children. So, for instance, when you look at the child on the left hand side, take a look at those circles under her eyes. Look how her head is lurched forward. Tendency is a child is trying to gain more airway, to get more oxygen, and they will tend to portray or protrude their head forward. The boy on the right, again, circles under their eyes, but look how the lips are parted. You see that they're a mouth breather. You see a rolled lower lip. Also, this boy tends to almost look like a double chin. He looks like he's possibly kind of heavy, when in actuality, he is not heavy. It's just the way his lack of growth or the way his jaw is positioned that gives that appearance. We also would like to look at the profiles of a child. So, obviously, take a line, go down the face, and you can see where the deficiency is in growth. You can take a look at that lower third. Typically, we see a third, a third, a third. It should all be in proportion. Many times you will see that off, especially in the lower third of that face. The girl on the left, you'll see obviously retrognathic lower jaw. You see that her lips are parted, mouth breathing. You see the rolled lip. Take a look at the girl on the right. Again, you see deficiency in the lower third. You see a rolled lip, a little bit of lips parted, circles under their eyes. But look how that chin and the neck blend into one. We call that a funnel look. And obviously, it would indicate that probably that airway has not developed. And this child is going to have difficulty when she sleeps and the way she breathes and probably the development of her airway. So then, after we've taken a visual assessment of the child, we have an initial screening tool. And this is a HealthyStart sleep questionnaire that's excellent. It will get you into the trenches. It will help explain a lot to a parent. It will start that conversation. I can't stress enough how important this tool is. So here you have 27 of the most prevalent outward symptoms of sleep. Now, we're going to have a parent identify them, but then also put a severity degree onto them. So we would ask them to rank from 0 to 5, 5 being the most pronounced. So as a parent will go through, he'll go through each and every one of these symptoms. The last one indicates speech problems. You will find a lot of these children will have speech issues, because obviously the tongue is in the wrong position. The tongue is lazy. The tongue doesn't have the strength nor the endurance. And so it's very difficult for them to make the pronunciation of words. So the lower portion of the sleep questionnaire will ask you to check off what other areas that you see prevalent in your child. Sometimes parents will say, "Well, I have absolutely no idea what my how my child sleeps." That's okay. A lot of parents, we put our child to bed, we cross our fingers, we tiptoe out of the room and hope they sleep all the way through the night, not realizing what is going on at night. So I sometimes ask a parent, you know what? After your child goes to bed, tiptoe back in there and take a video, just a 5-minute video of your child sleeping. Or maybe take a chair in there and just sit and listen. If you can hear your child breathe, they're mouth breathing. Now, if a child is snoring, obviously they're mouth breathing, but not all mouth breathers do snore. So, mouth breathing is really the probably number one. It is the number one culprit of what we're looking at. So, I wouldn't just rely on snoring. I think sometimes that gives us um, a false hope almost. We find that 50%, approximately 50% of the kids will mouth breathe. So I would kind of give a little explanation. Snoring is not taking the shutters off the house like grandpa used to do. Snoring just means, can you hear the child breathe? And the same goes with mouth breathing. So, a research study was done on over 500 children, and it was very interesting to see what the results were and how often frequent and what the outward symptoms were that seemed to be most prevalent in these children. So, the results of these studies basically saw that mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom study. 9 out of 10 children had one or more outward symptoms of sleep disorder breathing. 60% of the sample had 4 or more outward symptoms. 1 out of 5 children experienced bedwetting. Just want to take a moment to kind of elaborate. This is children at an older age. I was quite shocked. It's actually 18.6% of the kids would bedwet at a later age. I had no idea it was that prevalent. And obviously, over the last 35 years that I've been doing this, I see it more and more frequently. But just to put in perspective, if you have a classroom of 20 kids, 4 of them will be bedwetters at a later age. So it's not something typically a child advertises nor a parent. So you might find that that sleep questionnaire might come back with no indication of bedwetting. So I typically, when talking to a parent, will just use a third person and say, often we see children that have a lot of these outward symptoms also have a bedwetting issue. And I just pointed that out because we see it more frequently than we think. Watch the reaction of the parent to the child. You'll know immediately if that is also an issue that this child might be experiencing. If it is, it's an explanation that we just want to know because we want to see what changes we're making by changing how they breathe, how they sleep, and the development of their airway. The last point is between 4 and 12 years of age, 92.6% of these outward symptoms will not self correct, and 30% will worsen with age. So the thought is if you see it, you're going to treat it. A parent doesn't want to hear that their child has less than 8% chance of these outward symptoms self correcting. It's not good odds. And those odds are pretty slight. And do you really want to jeopardize your child's health, not only for today, but for their lifetime, based on that statistic? So I bring that out. Remember those numbers because that is a really important piece of information that parents need to know when they're evaluating whether their child will go ahead with this type of treatment. As we said, mouth breathing was the number one, 43% of this study, which was 501 children. The reason why mouth breathing is so critical is because when we open our mouth just a half an inch, it basically reduces the airway by 6 millimeters. Well, a 7-year-old only has an airway that's 7 millimeters. So that child is trying to breathe through 1 millimeter of airway. Take, for instance, a coffee stirrer. That's about a millimeter of airway. I don't know if you've ever tested it or tried it. I did. I thought I would spend the entire day breathing through a coffee stirrer to really experience what these children were feeling. Well, I made about 10 minutes to 15 minutes, and I had the most massive headache I've ever had in my life. Now, I tried to take Excedrin and everything else, nothing worked. The only thing that helped me was going to bed that night and waking up in the morning without that headache. But think about that child who's mouth breathing. They don't have the opportunity to ever overcome those headaches. That headache is going to bear with them each and every day. So we'll talk a little bit about headaches as well, but it's something to think about. So what is the ideal airway that we're looking for? Think of a garden hose. That's what we're looking for. When we mouth breathe, what happens to that garden hose? It kinks. It reduces the amount of oxygen that can be absorbed into the body. So those are some images that might help in this conversation, but it's really an important part to understand how critical mouth breathing is for these children. We also find that children who do mouth breathe, we see 8 other outward symptoms, and these can include snoring, difficulty listening, talks while sleeping, allergic reactions, fidgets with their hands, restless sleep. You can see the rest of the list. So, the implications of this study, basically, the findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. There was an interesting study just done where they actually found that they could see sleep issues in children that before they were even born. One way of thinking about that, think about the mother. If the mother has sleep issues, there's going to be a reduced amount of oxygen that basically can impact the fetus. So history kind of repeats itself, doesn't it? Another point is begin treatment as early as possible to ensure the most permanent changes. Identifying outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. So let's talk about airway and addressing the habitual issues. So, as I said before, when we're looking at an airway, mouth breathing, a compromised airway is something similar to a coffee stirrer. And the ideal is obviously a garden hose. So these images basically help in this conversation. This is another interesting image. So here, this is a 7-year-old boy, and this is what we would anticipate his airway. This is a 7 millimeter airway right here. Not very big, right? Well, imagine if they're mouth breathing and you're going to reduce it by 6 millimeters. Guess what? That child's struggling to breathe through this type of opening, which is basically only giving them 11% of their airflow. So, quite significant. Why is this happening? Why do we see more and more children? Well, it has to do with the development of the oral cavity and the different avenues and aspects out there that contribute or hinder that development. So when we look at pacifier use and bottle use, all of those kind of mechanics basically depress the tongue, prevent the tongue from swallowing the right position, and starts restricting or constricting the arches with the suction that occurs when they are sucking on a pacifier or even a bottle. Lack of breastfeeding is another, obviously, contribution to this issue, especially because breastfeeding actually helps the development of not only the tongue, but the strength of the lips and the development of the oral cavity. Now, in this day and age, it's really hard to find parents that had the opportunity to breastfeed for 2 years. Most parents maybe get 6 weeks off. They try to do their best. You hear that they say, well, I couldn't breastfeed, but I pumped and I gave them breast milk. That's great. But again, the mechanism that we delivered that breast milk was not the best. And that has caused, obviously, compromise in the development of the oral cavity. A soft diet is another one. Look at these crazy things. Graduate puffs, the nutritious snack that melts in a baby's mouth. we're not using the chewing motion that is necessary to help with the expansion. Back in the caveman, they would tougher the meat, the better. And obviously, we never saw any of these kind of characteristics that we do today. So it's hard. You never hear a child say, please give me the most chewy piece of meat. No, that never happens. But those are the kind of things that probably would be better for that child, just to encourage that development, that arch expansion that happens. What do we look for in a child to help us identify again? Well, open mouth, an open bite, tongue thrust. All of these are basically characteristics that usually is a result of pacifier or prolonged bottle use. Even finger sucking or thumb sucking can contribute to that. So when you see a child with an open bite with a tongue thrust, you kind of know what caused it. When we look at the airway, just a little bit of an overview, the nasal cavity, the oropharynx versus the nasal pharynx. These are all contributors to what we're talking about. Hard palate versus soft palate, where the tongue is placed, what happens to the tongue with the swallow. So these are all important avenues to understand when we're talking about this issue of sleep, breathing, and airway. We talk a lot about mouth breathing, so let's talk about the way we should be breathing, and that is nasally. So what is the function of the nose? Well, the nose has 5 functions. It serves as an air passageway. It warms and moistens the inhaled air. Its membrane traps dust, pollen, bacteria, as well as other foreign matter. It contains receptors that sort out odors, and it aids in pronunciation and the quality of voice. So how many times have we seen children like this? Please note, this car was stopped. The parent put the safety belt behind them because it was rubbing against her neck. It is not moving vehicle. But you'll know that, as we said, mouth breathing occurs in about 43% of the children. So this is an interesting video. I love showing this because this is basically sums up what we're doing, why we're doing it, and what we typically see in these children. So, as we said, mouth breathing while sleeping does not improve. Actually, in 92.6% of the kids. This is incorrect here. So, let me play this video for you and listen.
That was holding it. Still holding it. Trying to take in air. There he goes. And now watch. He's holding it. He's holding it. He's holding it. He's holding it. Still holding his breath. And now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway. I'm opening his airway. Just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
So how interesting, right? Well, This is something we can accomplish with each and every child. Not only can we bring that jaw forward, but we can train them to breathe through their nose. We can also place and make sure that tongue is in the right position because we have myofunctional therapy built into each and every appliance. So, with the Healthy Start, our idea is to recreate or provide to a child the proper habits, allow them to promote the proper growth and development of their oral cavity, create the proper habits such as proper swallow, proper breathing, as well as allow the growth and the development of the oral cavity to happen to the best or to the most beneficial position that we're able to in that child. So, what is normal airway and what is a constricted airway? So, the child, these are two different children, age 5. The child on the left, a 5-year-old, has a restricted airway. You can see the narrowness of that airway. The child on the right has an open airway, more of a normal airway. Well, okay, we can see a normal airway and we think, great, the kid is fine. Well, if they have a habitual problem, such as mouth breathing, it is not okay. Take a look at what happens. This is the same 5-year-old that you have an open airway. Just by opening your mouth a half an inch, you're going to constrict that airway by 6 millimeters. So now we no longer have a normal airway. We have a constricted airway. So that's part of the issue when we talk about mouth breathing. This is an interesting case. So typically, this image is from a CBCT scan. It is hard to get CBCT scans in a child, but it's a tool. And with every tool, there are positives and negatives. So no matter if you're using a cephalometric x-ray or you're using a CBCT scan, it's the vertical position. So it is the best of all worlds when we're looking at it. Obviously, the ideal would be to be able to take a scan when the child is sleeping in the horizontal position. The muscles relax, the airway would be even further compromised. So always, you have to realize that it's not 100%, but at least this is the best it's going to be. So typically, how they determine what a normal airway is for a specific age patient is we take the age of that child starting at 5, multiply it by 10, and we get typically what that airway would look like. So this child on the left basically is 9 years old. So we would anticipate an airway of 9 times 10 or 90 square millimeters. Obviously, he presented at 53.6. He is compromised. So as a child develops, we max out at age 17. We would anticipate an airway to be between 150 and 170 square millimeters. Bad news is at age 21, our airway starts to deteriorate over the course of our lives. So here in this particular case, the 9-year-old has a compromised airway, a habit corrector. This is the first appliance in the HealthyStart system, was given to that child for a month. When they came in, we took a second CBCT scan with the appliance in his mouth to determine what kind of airway we were expanding. We'll take a look. 337 square millimeters. Now, that's 6 times larger than what we would have seen at the initial CBCT scan. But think of it, it's twice, over double what we would anticipate seeing in an adult. That's huge. So we are right now currently in about 6 different research projects that are evaluating that kind of dimension, correction, change, duration, longevity of this kind of condition. So this is huge. I love this example because this is what our technology is bringing. This is where we're heading with this conversation. So I just want to strengthen and stress that point of view because it's such an important piece of what we're talking about. So kind of a recap, we've been talking about mouth breathing and snoring, and we realize that that is a result of extended bottle feeding, pacifier use, poor tongue position, abnormal swallowing. Usually sugar processed foods can be have an effect. Poor oral habits, thumb, finger sucking, lip sucking, tongue thrusting are all contributing factors. So mouth breathing and snoring will lead to a compromised airway. And in a compromised airway, we will have a reduced airway, a restriction of airflow, reducing oxygen, increasing CO2. It does affect brain function, immune and endocrine systems. Swollen adenoids and tonsils appear, low tongue position, tongue thrust, underdevelopment dental arches of the overjet, open bite, and crossbite. And from the compromised airway creates a condition called sleep disorder breathing. And with sleep disorder breathing, we see those outward symptoms, which can include restless sleep, ADD, ADHD, bedwetting, chronic allergy, nightmares, daytime drowsiness, aggression, difficulty in school, frequent infections. And there's a continuous list of more symptoms that are included. What do we see when we take basically an MRI of individuals that have basically sleep issues versus those individuals that have normal sleep? So this MRI, the first 3 top images, is brain function with normal nighttime sleep. And you can see the activity in the red and the yellow. Now, the bottom 3 images are basically an MRI after 1 night of sleep deprivation. I think we can see one little spot. So you can see how detrimental lack of sleep occurs with just brain activity. This should also be a lesson to all of us. Any of those all-nighters that you pulled in college probably wasn't the smartest move. So anyways, very powerful kind of image for you to remember. So let's talk about treatment. Why the HealthyStart? What is HealthyStart going to do? And why is it so important to look at these children and look at them young and make those changes? So HealthyStart is a division of Orthotain, and Orthotain has been around for over 52 years now, and 4 million children have been treated worldwide. The system consists of different series of appliances that are used basically based on age, or more specifically, dental maturity. So if we have a child who is 5 years of age, we would go to this type of system. Now, we would start with the first appliance, which basically evaluates and addresses the habits. It eliminates the improper habits and creates the proper habits with the myofunctional therapy that is built into each one of these that's activated by a swallow. All the child has to do is wear it. And as they're sleeping with it, it's automatically reinforced. The second appliance will be used to help guide the incoming teeth, expand the arches, correct any overbite, overjet, open bite, gummy spine, class 3, crossbite. This is a miraculous type of appliance. When the laterals start to erupt, they will go into the third and final appliance, which will again continue guiding, continuing expanding, and making those dental corrections in that child. We have it for preteen, which is ages 8 to 12. We also have teen and adult greater than 13. And we start at age 2, but we do have 6 patients that are age 13 months. So we can do a lot at a very young age. So what root causes are we addressing with the HealthyStart? Well, we're going to be expanding the dental arches. We're going to establish nasal breathing. We're going to train the tongue. We're going to eliminate the bad habits. We're going to advance the mandible to correct the overjet. We're going to encourage proper facial and body growth. And we're going to correct most orthodontic problems. We kind of say we're going to look at the health issues of the child, frosting on the cake, we're going to straighten the teeth at the same time. So let's talk about that first appliance, the habit corrector, that has the built-in myofunctional therapy. So here are some of the features that you'll see. We have what we call palatal expanders, or tabs, which help with the expansion. The tongue will press against each one of these and create almost the space for the tongue to rest. Now, when we talk about the tongue position, say the letter N. where that sound ends is where that tongue should be at rest. Most of us say it's not. So what we have to do is get that tongue up, but we also have to create the space so it can be in that upper palate. So these expansion tabs or palatal tabs are what can help us in that direction. We also look at these, what we call prongs, and that's to prevent the tongue thrust, but also tell the patient, indicate to the patient the proper time to retrieve their tongue during a swallow. You'll see that there's a ramp that we call it a lingual shelf, but it's a ramp that actually helps guide the tongue up, positions it up in that space where we said the letter N, and we continue it. So every time that child swallows, it repeats the proper habit. We swallow 1 time a minute at night, 2 times a minute during the day. So just by wearing it at night, we're repeating that habit 500 times each and every night. So it's pretty enforceful, but it also is done in such a passive manner that it's amazing. And it's amazing the changes you're going to see. We also have what we call pads that can be incorporated into the appliance, which helps with the open bite. So we'll make the bite correction even faster. On the lower portion, there are 2 tabs that prevent that lower chin from drifting back, even if they try to open their mouth. So it's very effectual. All of these have a certain purpose so that we can guide, maintain, and encourage the proper habits. Another way is we want to see that tongue placement. Many times you've probably heard someone has an improper swallow. You might be saying, what the heck is an improper swallow? Well, the easiest way to assess this and help a parent understand is just have a glass of water there, a cup, have a child take a swallow. Sometimes we tell them, wow, you look pretty tired when you take a glass of water. Please don't tell them you're going to evaluate their swallow because you will not get an accurate evaluation. So as they take that glass of water, you want to see how that swallow occurs. Typically, we should only see the muscles moving in the neck portion. However, many times you see movement within that lower third of the face. The lips purge. They have to do a lot to get that water down. Sometimes a parent will say, oh my gosh, they can't chew with their mouth or closed. Food comes out. It's very difficult. All of that are indications that there is an improper swallow. But during our treatment, every time a child comes in, I want you to have them take a swallow of water and see how much improvement, and make that notation in their file, because you want to, indicate to a parent, indicate to the child that they're making huge improvements that maybe they don't even realize during the month or 6 weeks that you don't see a child. Again, we talked about the rate of swallow. We swallow 2 times during the day, 1 time at night. Here is a sample of 220 patients and the habit correction that occurred within the first 5.5 months. This is to give the doctors an indication of what we're seeing. And if we're not seeing those kind of corrections, we really want to know. We want to make sure we're doing everything for that child and we're addressing their needs in the most efficient way. So take, for instance, headaches. We found that out of the sample size of 220 patients, 40 patients indicated they have headaches, which is about 18%. We found out that 98% of the cases had improvement, 94% the mean correction of those with improvement, 91% mean correction of the entire sample, and 85% of the cases with 100% correction. These are great numbers, and it's to help you be more efficient in your treatment planning so we can gauge where that child falls. And if we're not seeing what we want to see, obviously some treat faster, some treat slower. We know this, but we want to kind of have an average so that you're gearing yourself and you understand where the process is. So here we go through the different 27 outward symptoms. Interesting conversation. ADD, ADHD, and sleep disorder breathing. What is so interesting to me is ADD and ADHD is basically a set of criteria that a child is evaluated and it is determined if they possess that criteria in order to have a diagnosis of ADD and ADHD. It is not a blood test. But what's interesting is when we evaluate a child for sleep disorder breathing, we use the same set of criteria. Can they be misdiagnosed? Absolutely. Most recent research showed that 85% of the children with ADD and ADHD had sleep disorder breathing, had sleep issues. It's a huge number. So, can they be misdiagnosed? Absolutely. My comment always is if you suspect or see symptoms or behaviors that mimic ADD and ADHD, evaluate the sleep first. Let's see where the kid lands. Maybe the whole reason is the sleep issue. Maybe sleep is compounding the ADD to make it look more severe. So, sleep is something that we should be addressing at every moment. And if we can make changes in a child, do it. We can make more permanent changes, and then let's see where the child lands. So, one of the largest studies that was done on ADD and ADHD is done by Karen Bonnick. She basically looked at over 13,000 participants, and she found that sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. Children with ADD and ADHD have little or no REM sleep. Remember, REM sleep requires oxygen. If we have mouth breathing, we have a restricted airway. If we have a restricted airway, we're not getting the oxygen that we need. In these children that do not receive REM sleep, we find they do have delta sleep though. Patients without ADD and ADHD have primarily both REM and delta sleep. In the research project that we did on 501 patients, we found that 25.2% of the cases presented with ADD and ADHD. So here's some long-term and not great statistics. In regard to ADD and ADHD, 50% of the kids are held back 1 grade. 30% are held back 2 grades. I got news for you. If it's a sleep issue, you can hold them back 10 grades. You're not going to make that difference. That child is still going to have difficulty focusing. He's still going to have difficulty participating in class, doing well, getting along with the peers. So again, evaluate sleep. Here's an interesting research project that was done on children that do have sleep disorder breathing. They found those children have 10 to 20 fewer IQ points. Well, in my world, I would say college or no college, but they went one step further. What was the value of an IQ point for a child over the course of their lifetime? They found that number to be $170,000. So again, interesting statistics to provide to your parents. So how does HealthyStart promote growth and development? Well, as we know, craniofacial growth basically ends, or majority of it ends at age 12. That's why we like to get in there before that age. So much craniofacial growth happens so early. Even at age 12, we see that 89% of the males have completed their growth and 94% of the females. Also notice in this, the growth that happens forward and down. This is what we're promoting, and this is what we're hoping to accomplish. So take a look at this child. You can see, basically, take their forehead. You can see how retrognathic that child is in the lower third. Look at the mouth breathing, severe overjet, thumb sucker, bedwetter, you named it. This is wore the appliance. This is 1.5 years later. You can see how much forward growth has happened in that child. With the HealthyStart system, a very large research project was done in the country of Finland and found that we gained 54% more mandibular growth than the control sample. That's huge. So we see that in these appliances. We also have different techniques that we can promote both the upper and the lower arch. We call it the MAX-A, and it stands for maxillary advancer. And the way the appliance works is these tabs here are used. So the tongue pushes against the tab. and it's going to drive the upper arch in a forward direction. At the same time, it's going to drag the lower arch in unison with the upper arch. There's no wall in the upper, so it really allows that upper arch to move in that forward direction. So here you can see an example, initial 1 month current. So you can see once we've gained that change, we see more normal growth and development to occur. Now we can also use a similar product. It's called the class 3 corrector. We tend to see either pseudo or skeletal class 3s. Obviously, pseudos are, as we call it, a slam dunk. Skeletals are a little challenging. Majority of the time, what we will convey to a parent of a child who has a skeletal class 3 is we can minimize that class 3 tendency. Be very careful, because with skeletal, it's very difficult to make a full correction. But obviously, if we can make and minimize it, it's only to the benefit of that child. So here's a case. Again, these tabs are used to drive that upper arch. There is a lower bumper in the lower that's going to hold it while we make the jump. Once the jump is made, we'll move into the habit corrector, and that growth will proceed. So here you can see a case that was used to make that jump occur. Typically, we see it in about 2 to 4 months. It happens very quickly. Treatment planning, all of our cases will go through a treatment planning schedule so that we can assist in providing you as the doctor the proper size appliances, and also kind of give you additional feedback on this case so that we can provide you with timing of the treatment, what we're looking for, concerns we have, so that we're your consultant. We want to make each and every child the most successful they can be. We want every patient that comes out using the HealthyStart to be ideal, to be the best they can be. And every piece of information, additional eyes on these cases, only make that more feasible to occur. So let's have some fun. Let's look at some of the cases. So here's a case here. It's a child who's age 7, came in. You can see their sleep questionnaire. Look at the considerable amount of items. I think there's 18. That's a lot. That's pretty serious. You can see a lot of 4s and 5s in these areas. You can take a look at the speech problems, very delayed speech, didn't say many words up until age 3 or 4. Obviously a lot of issues. So what was prescribed? It was the sleep question. It was the habit corrector. The very first appliance was introduced to the child. 2 months later, we had a parent fill out the sleep questionnaire to evaluate these outward symptoms that were indicated prior at the onset of treatment. Take a look. This is after 2 months. Pretty good. I mean, we have a few 1s, but literally so much change in just a short period of time. So let's see how he presented. Well, when he came in March 2015, take a look at the deep overbite. Look at the circles under his eyes. Not too bad. I mean, not as bad as what you would think looking at that sleep questionnaire. Look at the arch shape, more of a square arch. We're looking for rounded arches. So let's take a look at them. Take a look, keep a look at that overbite. This is March. This is a year later. Barely recognize the kid. Look at no more circles. The profile is better. Look at the roundness of these arches. Look at the overbite correction. It's just with passive nighttime wear. Now let's look at how the case is proceeding. This is 2 years later. This is just maintaining. Beautiful. What a change, just with passive nighttime wear. Here's another case. Again, a lot of outward symptoms on the sleep questionnaire. 4s, 3s, there's a 5 here, wetting the bed. 2 months later, 1 on bedwetting. That's it. Pretty good. So you can see, again, deep overbite, and you can see this is still in progress, but you can kind of see how the changes occur. Here's another case. Here's the initial. Here's the finish. Here's before and after. Here's how the process works. Obviously, primary teeth, deep overbite, appliance is inserted. As the teeth are erupting, you can see they're rotated. They're going to fit right into this. Here's the finished case. And this is what it looks like with the appliance. So the appliance is going to guide, direct, make changes, correct the functional problem, and also address the habits. Here's initial, beginning, and end. Another initial and finish. Here's an interesting case. This child's mom did not have any treatment, and I think she was 35 when she had surgery. Obviously, when she looked at her child, she saw the same thing she saw in herself. You can see the child, you see circles under their eyes, you can see the rolled lip. You'll see in a minute, you can see the profile. Look at the deep overbite, a lot of grinding of the teeth. So let's see how we progress. Again, a lot of sleep issues with that child as well. Here she is. You can't even recognize her. Look how beautiful she is. The circles are gone. Look at her teeth. You can see the roundness of the arches. She's doing a great job. So let's see the stability of it. You can see her as she is aging. Case still looks beautiful. Here she is again. Still the same. We allowed the teeth to grow in straight. The fiber bundles developed in that position, so there's very little relapse. Here's a child who snored, brucks, bad breath, ear infection. Here's about a year later. Here's another case. Again, a lot of fives. You can see, and this is 2 months later. Most of these have cleared up. You can see the deep bite. You can see basically the openness of that. You can see the arch. You can see the squareness. Now you see the roundness. Another spectrum, snored, brucks. Here's mid-treatment. Here's now 14 years later. With each case, we have an app. The app is wonderful because it basically records, encourages, provides rewards for cooperation with the child, but collaboration with the parent as well. So the app will record every night. We'll ask the child in the morning, did you wear your appliance last night? Did it stay in all night? Yes, yes. They get coins that they can deposit in the bank in town. They also get 30 minutes of game time, or they can read books. There's all different activities for them to do. At the same time, a parent is asked, have you seen any changes that have occurred in the sleep questionnaire? On Friday, we basically ask them to take a selfie. So cheek retractors will come with each app, with each case. And on Friday, we ask them to take a photo. All of this information is stored in the portal. So not only does a parent have it so that she can share it with other parents or neighbors or cousins or whoever it might be, but at the same time, you as the practicing doctor for this child is going to have this information in your portal. So during the 30 days or the 60 days, you do not see the patient. You actually have access to what they're doing. So prior to them coming into appointment, you can actually view exactly how the cooperation has been, what changes have made, and you can actually look at the case. So it's a great tool for you to use and obviously be able to make those differences. As we said, we've treated 40 million cases worldwide. We take safety and material. Everything we made is in the United States. We do clear ourselves to a class 2 medical device, which we don't need to do, but we want you as parents, as practitioners, to realize that safety is our number one concern. Our appliances are all FDA cleared. There's no latex. All appliances are BPA, BPS free, phthalate free, no silicone, and again, regulated to a class 2 medical device. So I don't know if there's any questions, but I hope I kind of went through it very quickly. It is just a brief overview. There is so much information out there that we want to share with you, and we have different educational tools that are available for you to get a greater understanding of this topic, but more importantly, learn how you can implement it in your practice. And this digital is really a great avenue. Not only is it educational, but it's also hands-on. So maybe Susie, if you want to take it away, maybe you can explain a little bit more about the digital.
Yeah, I'd love to. So, as Leslie said, we have a wonderful education platform, and I think our digital education course is probably one of our most popular ways that doctors are getting educated with HealthyStart. And the reason for that, I think, is because it encompasses so many different learning platforms. Our goal is to ensure that our doctors succeed. Our goal is that you see as many patients as possible. And I think that's the whole key. And with the issue with so many children having this issue, it's extremely important. So our digital education course is actually a 6-session course. So basically what we do is every Monday we send out a video series, and you have the entire week to watch the series. And then on Friday, we have a live interactive study club. The study club is fantastic because we actually bring on special guests every Friday, whether to talk about things like billing or how to implement HealthyStart in your office. This course actually includes you as the doctor, including your entire staff are included in this course, because we understand the importance of ensuring that your staff is on board. For you to be successful, your staff needs to be excited about what you're doing. The great thing about this course is it actually complements the ADA policy that Leslie was talking about earlier. So that policy says that it's the responsibility of every oral physician to become educated on assessing children with this issue. And that's what this course gives you, is a full comprehensive education. It also comes with hands-on treatment of 2 full cases. That's pretty exciting because we want to ensure that not only do you have this learning platform where you're able to learn digitally, you also are able to learn hands-on. So we're going to give you 2 entire systems for 2 children. So we give you a 4 to 6-year-old system, and we give you a 7 to 11-year-old system, so you can work with 2 children in 2 different age groups. The great thing about it is that I am positive that after learning the information you've learned tonight, there are 2 children that you already know who need this system, who need your help. So we send you out the 2 starter appliances so you can get 2 children started immediately. They start sleeping in the appliances, and they start benefiting immediately. Then we take you through the course, and we take you by the hand and take you through the entire treatment while you're taking the course. So it's a great way to learn. On top of that, another learning platform. We give you a $3,000 voucher to attend one of our destination courses. That actually includes you and 3 of your staff members. It's another fantastic way to learn. It comes with a clinical, so we actually bring children in and we do the diagnostic overview and those kinds of things, so you can kind of see how the whole system works while you're there with children, and it's all hands-on, so it's really great. We also send you a sample acrylic stand for your office with sample appliances. There's, as I mentioned, the interactive study clubs, but we also have a forum that you can join as well. The forum is great. We have a ton of providers that are in our forum, so you're able to network with other doctors, you're able to ask questions and learn from each other. Now, on top of that, we do provide you, of course, with training on pediatric treatment of sleep-related breathing disorders and how to identify it in your patients. But we also teach you how to increase your patient flow. We really want to provide you everything that you need to reach out to your community, including parent webinars that we'll help you with. We give you everything you need for your website to ensure that when a parent has come to your website, they can learn all about HealthyStart. We really want to, again, we're all about helping you to succeed, and we understand that educating the parent is a big part of that. So we try to give you everything you need to do that. You receive 18 CE PACE credits and 16 more when you attend our destination course. It's a really wonderful, comprehensive course. So as I mentioned, it is a digital platform to begin with, and so we have doctors from all over the world who join us on our course. And here's just some of the things that they are saying. So we have a doctor from Australia who joined. He said that the digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor in Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. And Doctor in Colorado, I've really enjoyed the course. We've identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we've already seen great improvement in his eating. And we have 3 more patients who will be starting next week. And that's something that I really love, that testimony, because Dr. Wright was actually only 3 weeks in. So as I mentioned, this is a 6-session course, and she was only 3 weeks in. But we had given her those habit correctors. We'd given her those starter appliances to start that came with her 2 free cases. She already had 2 children who were using them. The parents were seeing kids that felt better. You know, they were waking up in the morning feeling better. They were doing better in school. Their symptoms were decreasing. So anyway, the parents are seeing this, and they were telling other parents. And before you know it, she had parents calling her, and she had appointments set up for. Anyway, it was just exciting to see. It's exciting to see those things happen. American Dental Association took our course, and they said it was ingenious, and I think that's pretty high praise. So to give you an idea of the investment, so typical investment for a HealthyStart certification is $3,400 for the digital course, and that includes your entire staff, which is pretty awesome. And then the in-person destination course includes you and 3 staff members, and it's $400 to attend that. But for being on this webinar tonight, we're actually doing a 2-for-1. So for that $3,400, you can attend that digital course. You can get those 2 free cases. It includes your entire staff. Plus, you can come to our live course as well. Still bring your 3 staff members, and it's all included in the cost. So pretty awesome. You know, again, I just think that one of the best things, and one of the things that I love about HealthyStart, is we're all about wanting to ensure that you succeed, and we're going to do everything in our power to help you do that, including giving you this type of a system at this cost. So you can register very, very easily. You visit www.openairwaydentistry.com, and there's a register now button. So as you see down there, there's a class that just started. It started on May 20th, so it started this week. So it's perfect timing. You can jump right in. We can get you your first set of videos. You'll get caught up just immediately. So it's perfect. So you just go to register now. It'll bring up the form like you see here on the page. Fill that out and hit apply, and we'll send you out your welcome package immediately with your 2 free systems, or the 2 free appliances with your systems to get started. And I will send you out your video, and you can get started immediately. If you have additional questions, please do not hesitate to ask, or if you would like to enroll in a different way, or whatever it is you'd like, that's my email address right there. You can email me directly, and I would be happy to help you get started. So the time is now. Don't wait. There's too many kids with this issue. So I always say that because, you know, I don't know. I think once you learn this information and the light bulbs click on and you have this information, there's no going back. So anyhow, so Leslie, is there anything else you'd like to add?
Well, I'll challenge all of you. So we all have a nice, beautiful, hopefully the weather is going to be great weekend ahead of us. And I challenge you. So this weekend, while you're just, you know, barbecuing or shopping or going out for dinner or doing whatever you are, take a look at the kids around you. I think you're going to be shocked. Take a look at those visual cues and just kind of keep a tally in your head. I think tonight will change the way you look at kids. And I'm always so excited to hear from doctors that tell me, you were so right. I just had no idea. Maybe it's your own child that you're just going to take with fresh eyes to take a look tonight. Or maybe you are going to take a sleep questionnaire and fill that out. So take this weekend, take a look. I promise you, it's going to change the way you do dentistry, and it's going to change the way you look at children. So I'm excited to hear about your adventure into this arena, and I hopefully look forward to seeing you on our digital course to learn more and to start reaching out and addressing the needs of our patients and the children around us. So with that, I hope you have a wonderful evening. Thank you for joining us. Susie, thank you for your efforts. And again, I look forward to seeing you on a digital.
Yep. Thank you guys so much. And Leslie, thank you for your time tonight too. Everyone have a great night and have a wonderful weekend.
Happy Memorial Day. Bye-bye.